because this is the accumulation of all of the presentations I've done, turning it into a tool to help create change. And the change that has occurred, my multi-specialty 7-hospital organization will now be choosing a proactive management model using designs and understanding behind what I'm going to show you here. I was speaking to a special agent from the DOJ who was investigating a nursing home. Now his special agents are coming to get educated about these issues due to this presentation. And I found this to be very powerful, and just looking at the other options, maybe things we didn't think about when we had the best intentions. You need to know, of course, where I come from, and I've worked as a utilization manager. I've worked in hospice and palliative care, and I worked in nursing homes for almost 3 decades. So instead of looking forward, I'm looking backwards, and that's how I visualize things. And for those of you who know how I think, I like to do not didactic, but didactic slides, so you can get a different feel for what for a presentation you might hear in a different manner. So I have no disclosures. I guess you can get CME credit if you want. I'm going to give a case study because I think this helps illustrate, and this is going to be an interactive discussion, but this will help to illustrate the issues that I'm talking about. So after years of working in the nursing home, I would see these patients all the time, or we'd see in my offices, or we'd see these patients in the emergency room. In this case, it's an 86-year-old woman who comes in to see you after passing out. She's walking outside in the backyard taking care of her poodle. And she has stable angina, and she occasionally gets a little bit lightheaded. She's got a known aortic stenosis. She's short of breath now when she walks across the room. She does have a little bit of edema. She has a front wheel walker, but as most of us know, they don't usually use it. Feels generally more fatigued, weaker, and she's lost 12 pounds in the last year due to change in appetite. She had a workup for that, was unremarkable. You can see her medical problems there. She's generally inactive and rarely gets out because she's just not up to it. And she states that she hasn't had the energy she used to for years. She doesn't drink or smoke. Sorry, I'm right at the wrong place for my bifocals. She now lives with her son and daughter for 2 years. Both work. She doesn't drive, cook, or pay bills. She's mildly demented. She's that type of dementia that we see in our patients that they don't want to admit they're demented, so she's just a little bit confused. Her family states she's just a little forgetful. She wears glasses, hearing aids. Daughter states she just needs more help because she's losing her strength. This is her previous surgical history, hysterectomy, chole, and she's had a hip repair where she had a heel ulcer and some delirium, but she's over that. These are her medications. Does that look like a typical medication list? This is her exam. Those are her vitals. She's alert and oriented, easily distracted. You can see she has no JVD. Her lungs are actually clear. No hepatojugular reflux. It's her echocardiogram. And those are her labs. So just to be interactive and get an idea of where this is going, imagine what you would do with this patient, or can you give me some ideas what your colleagues or what might happen to this patient if she went to the emergency room? What's the next course of action? What can you see your colleagues doing? What do you think you would do if this patient was in your office, or if this patient was in the ER? Can you imagine that that patient would get a cardiac consultation?
The heart failure clinic.
Go to the heart failure clinic, right. So very typical to see that in our advanced geriatric population. We are very organ disease-based mentality. We think we're working in their best interest because that's what we know. And I would offer that perhaps there are some other decisions that need to be made. This was a typical answer I got, that we would send her for an angiogram and at least send her for a cardiology consultation to make sure that this was something that we could treat with her heart, and she'd need an angiogram to define the real issues at hand. Here's the problem. And the problem is that we don't look at the advanced elderly except as one homogeneous group. We do a great job with the pediatric population, but when you get to the elderly population, They're over 65. I know Joe's going to be over 65 soon. Just remember. So where is this patient? Where is this patient on the life cycle? Is this a 65-year-old with physiologic, or 86-year-old with physiologic reserve? Have they lost their physiologic reserve? Is this a terminal patient, a pre-terminal patient? And if, or does it not matter? We're going to treat them all the same because, you know, it's over 65, it's a geriatric patient. I gave all of these indicators in this discussion that you can easily identify this patient as a pre-terminal patient, and maybe even as a terminal patient. How many people would have recognized this patient as hospice appropriate? Quite a few. Yeah. When the story that gets told is that San Diego Hospice went out of business for their unethical use of admitting patients to hospice. The second part of that story is that Sharp Hospice was evaluated, and we were told we didn't have a penny of deficiencies or inappropriate referrals to hospice because we created the ethical story as to why patients were actually terminal. When we got our Medi-Cal evaluation, we were told that we were the hospice for which all other hospices in the state of California were compared. Why? Because this information tells you ethically and medically where this patient is in the life cycle. If you go back and look at the articles that talk about weight loss, by the way, I'm going to point out some other things here. Patients, if you take weight loss in a patient, 10 pounds or 5% of their weight, the two-year mortality rate for involuntary loss is 28%. That is not backwards. If you lose weight intentionally, that's been shown in other studies for the advanced elderly, you will die more quickly, even than unintentional weight loss. So I'm always confused when I see my Medicare STARS question of do they have a BMI of 35 or more and what we're supposed to do with that. Because the medical evidence is 66, 76, 86, you're at higher risk of losing muscle mass when you tell them to lose weight, and that muscle mass is critical to keeping them alive. How many people knew if a patient had an incident heel ulcer, mortality rates were so high? And are we seeing that when we see these patients when they walk into our offices when we're perhaps focused on something else? So what do you do with a patient like that? 7 out of 10 patients will be dead in a year if it's had an incident heel ulcer, and if you do a vascular repair, it's still 6 out of 10. Those patients didn't get bad treatment, and why is it even if you repair them that they die? And that's because we're talking about the whole body system that's undergoing change and getting weaker.
Hey Dan, is there a definition for pre-terminal patient in terms of timeline?
6 months to about 2 to 3 years. Yes?
Interrupt for a second. So are you basically saying that for those patients who are over a certain age, we should not be telling them to try to lose weight?
Absolutely.
At what age are you sort of making that recommendation?
That's a tough, as they get older, and it probably has to do more as to when they start to lose their physiologic reserve. But what happens when people lose weight intentionally is it's 75% fat and 25% muscle. We're losing muscle as we get older anyways. 8 to 12% after the age of 40, accelerates after 70. You tell them to lose weight, that goes even quicker. The sooner they get to a certain point of muscle loss, they're dead. So I would not be telling anybody, even with a BMI of 40, to lose weight.
Dan?
Yeah.
I have to object, I'm sorry.
Yeah.
I do a body composition
Yeah.
analysis on all my patients now.
Mhm.
I know their body fat and I know their muscle mass. I live in the age of I live in the location
Mhm.
of healthy seniors all over the place.
Right.
80-year-olds running marathons and playing golf 5 days a week and all that sort of stuff. I would accuse that of tunnel vision
Yeah.
because, my whole practice is a war on body fat
Mhm.
while I increase muscle. So
I
I
could-
got these
yeah.
people in the gym. So I've got them losing body fat, losing weight, getting their BMIs healthy, but maintaining or gaining muscle. And you're not going to tell me that I'm not adding to their longevity.
I am going to say we said exactly the same thing, but you didn't see it.
Okay.
I'm not worried about age. I'm worried about that ratio between fat and muscle. And if you take the average geriatric person that isn't from Palm Springs learning to do that, and you tell them and they do not exercise to keep their muscle mass up.
Well, some people need
Yeah.
to lose weight at every age. Lean and fitness means longevity.
Yeah.
And there aren't that many fat 85-year-olds. I mean, some
Right.
people make it, but
Some people do, and I think this goes back to what we just heard. We have to be careful with the knowledge that we have, and we have to use it in the construct of knowing the physiology behind it. So I don't think we said anything different. So. Having said that, we learned the statistics of delirium, and we learned previous studies showing you that for a custodial patient who has a low albumin, low hemoglobin, and low cholesterol, the mortality rates for those patients are 84% at 1 year. That has to do with that inflammatory process of having too much interleukin-6 from your adipose tissue. What's that look like visually? Well, the patient loses weight unintentionally. How do you know which side? Well, you kind of know they're moving along in life, but how do you know if they're on the right side of that curve or the left side of that curve? Well, you can see the delirium puts them farther on the right side. The heel ulcer puts them farther on the left side, and the biomarkers put them even farther. How many people saw that? I know that people over here raised their hands because they could see the picture I was creating. We generally see these patients in the outpatient environment when they're coming in because they passed out. And what's the story telling us? There's more to this that meets the eye that I think we've been passing by and not recognizing.
I'm sorry.
Yeah.
And what about the polypharmacy that this patient was on?
Well,
Flexeril,
yeah.
all that
Can you
medication,
speak up?
didn't
If you're gonna
address.
speak up to the audience, not to the speaker, please.
Yes, I'm also concerned about the polypharmacy that this patient was when the event happened. Patient 84 with Flexeril and another medication.
Well, you're right on track because there's other risk factors. And one of them at the bottom I talked about is polypharmacy. Cognitive decline has prognostic risk. Patients who are depressed with cardiac disease, 60% increase in mortality, and social isolation increases their mortality by 30%. This patient has multiple risk factors, and multiple institutions would take this patient for a cardiac consultation before they've discussed the questions I'm about to ask, and they didn't even visualize that this patient may have 6 to 24 months to live. So what is this patient's biggest concern? Or what is your biggest concern for this patient?
Does she have a pulse? Advanced directive? What we go to do? What she wants?
Well, I think I agree
What
with...
she wants?
I agree with Dave. This is the most overtreated and underserved population in the country. We automatically see for many people that this is a cardiac case, and I deliberately wrote this out as a frailty case because her cardiac condition was stable. There's no indicator she's having a CHF exacerbation. She's had aortic stenosis. We've known that for 10 years. But these people get overtreated routinely, and we don't ask them what they want. We kind of push them down a pathway because our knowledge is based on sincere but incomplete information. Yeah.
So, maybe you're perhaps going into this, so...
Jim,
don't
speak
answer.
up, Jim.
You're perhaps going into this, but so, don't answer if it's going to show up in the slides, but the social dynamics of getting the people, and you've talked about this before, and when I've heard you speak, of getting the supportive family members, including the one that lives in San Diego and this one that lives in New York City, all on board to get on board a palliative care program versus, hey, let's be aggressive and treat mom and try to get her back up where she was. Can you speak to that, or does that come up?
Well, I don't address that directly in this presentation, but I think you're exactly on board. And what I call that is pre-direct care. We use our professional skills to anticipate the catastrophic event or the issues and the questions which are going to come because we know we have the anticipatory guidance for the adult population just as we do for children. And we need to do that in the context of the patient's family so that they're all morally resolved. Because what I found with these populations is just like with code status, when you give them full disclosure, they say, I was full code, now I'm no code. When you tell them about the true implications of feeding tubes, we've moved from everybody getting a feeding tube to nobody wanting them. And when you give them full disclosures about the consequences of hospitalization and surgery, what happens? But they need to be morally resolved. It's the right thing. And I don't want to wait and be there immediately, which may be appropriate for a younger and healthier population. But for this dynamic, for this demographic, it's not acceptable. And that's also why you need to be contacting those have a proactive conversation with the patient's family. But they need full information. They need full disclosure about what we're actually doing to them.
Again,
Yeah.
on your last slide, the
Mhm.
first question that you had, do you mean what is our biggest concern for this patient, or do you literally mean what is this patient's biggest concern?
I should add another question here. It's what's the patient's biggest concern? I agree. What do they want? What do we think the patient's biggest concern is? Do we have complete information on this patient? Is it really her heart status, which tends to be what we're drawn to because, that's how we present things. And then, how many people really want to know? Is it, one of the issues we talked about yesterday is, whether the culture is ready to change. And we also know that when doctors reach certain points in the care of a patient, they have to face their own mortality every time we tell them that they have a terminal patient. Or when they go to say something to a patient about their own terminality, the patient's terminality, they're thinking about their own. When you read Atul Gawande's book, he brings this up. It's a great point. The problem with Atul Gawande's book that I have, when I read it, is why were so many of these patients even seeing him? If they'd had proactive conversations from their primary care physicians or in a different environment, maybe they would have chosen not to have the surgery. And that's only some of the questions. These are the questions we need to ask, and I realize this is a repeat for some of you for these first slides. But what is this patient's risk of developing delirium if we put him in the hospital? Yeah, it's 63% to 80%. There's prognostic modeling that tells us that. This is another tool. Just pick a tool and use them on your patients. And even, by the way, if they're low risk, they're still risk. Why do we care? Because we now know that delirium has permanent consequences. And if you can foresee for your patients, fill in that piece of information that they don't know, and the family, they may choose otherwise. We know that these patients die quicker if they develop delirium. The ratio is about 200 to 700% higher. And that if you want to put a tool in your pocket, it's 30% mortality at 3 months to 80% at 3 years. When I speak to surgeons, most of them, or people in the hospital, think it's the direct brain insult. But Cyril, when I gave this presentation to Sharpie Steely, how many people in the audience raised their hands when I asked them, have you ever seen a patient get moved from one facility to another and become delirious and confused? At least half the audience raised their hands and say, we've seen that. It's a warning sign that, and a tool that we don't use. How many people see that documented in the chart, delirium? Or for discharge from the hospital? You're at a good facility, we're lucky. The state-of-the-art facilities across this country are having their staffs and their nursing staffs document delirium for every nursing shift and creating state-of-the-art protocols, which is what we're going to be doing at Sharp. I showed this. People asked me last night, well, what do? I go to the cardiac literature. I took a lot of the cardiac slides out because I didn't want to talk for too long, but this is their literature. If you take a patient for cardiac surgery and develop delirium, or not delirium, your risk of cognitive decline at 12 months is statistically significant. And it's on the borderline of being more significant than those patients that don't develop delirium. But that's because they did this study on people that were too young. Most delirium starts after the age of 70. I showed patients, I showed the surgeons that the risk of dementia, if you survive, it can be 10.5 times higher. You think your patients want to know that too? So when I get an 80-year-old that comes into my office and says, I had a knee replacement 10 years ago, but my risk profile, but I'd like to do it again because it was so successful, you have to have a different discussion about their risk profile. These are multiple other research articles which have shown permanent cognitive decline, permanent changes when patients develop delirium. And that is actually the natural course of delirium. It doesn't go away. It looks like it goes away, but then it returns. I gave this presentation last year, and I had a discussion with a couple of geriatricians. I was referred to a couple of geriatricians for a project, and I'm aware that I may overstate the association between delirium and dementia. It's an association, not a causation. That's great for academic research. In real practical terms, however, do you think your patients care whether they lose their memory from dementia or delirium? They don't care. You know, if they can't remember their family, if they have to move to a higher institution, it doesn't matter. And although I think that academic issue is important to develop treatments, the prevention of delirium should be the standard of care in this country if we want our patients to do well as they get older. The prevention of delirium causes higher mortality, institutionalization, that's what patients are afraid of, doctors are afraid of mortality, readmissions for administrators, and it also is associated with higher functional decline. And what do we know the patients say? 74%, about 3/4 of patients, and 90% respectively, say they would not undergo a major intervention if there was a significant risk of functional and cognitive decline. They wouldn't do it. And they're less concerned about dying than they are about living poorly. It's a different study. I haven't shown anybody. This is a new study. This was actually published, however, 12 years ago from the British Medical Journal, and they asked them, well, if you survived, you had a hip fracture and you survived, what would be acceptable outcomes? 80% said they would rather die than live in an institution, even if the hip fracture was repaired extremely well, 8 out of 10. So this is something that we should know to help our patients do better, and that is, what is this patient's anticholinergic burden? Anybody know? Anybody calculate it? This is a huge thing that we rarely see in our institutions. At Sharp will now be giving anticholinergic burden scores on every single patient that comes into the hospital, because it precipitates the outcomes that we're trying to prevent. The categories of medicine that put patients at the most risk are sedative hypnotics, all those sleepers we put them on, anticholinergic medications, and then polypharmacy. Polypharmacy is greater than 6 pills. Anybody have? Well, you do, because you're doing such a good job. But how many of you see patients routinely on less than 6 pills in their geriatric population? The most overtreated and underserved population. Patients come in like this, and I'll show you what we do. So, just to show you how difficult this is, which medications here have anticholinergic activity? Metoprolol is 1 point, Dig is 1 point, allopurinol is 1 point, furosemide is 1 point, oxybutynin is 3 points, Paxil is the only SSRI with anticholinergic activity, Flexeril is 3 points, Tylenol PM is 2 points, so you're already up to 13. This patient is doomed if they are put in an environment that accelerates their cognitive decline. This is what a palliative medication list would look like for the same patients, and this is the actual way we treat these patients. When they come onto our transitions program, we clean up their medications lists. They suddenly have their energy back, they feel better, they're not falling, they're not weak or short of breath or fatigued. Let's go back though. I stopped some interesting medications here. I stopped atorvastatin. What do you think the cardiologists think about that?
It prevents stroke.
Yeah, we'll see. I stopped their Dig. Why? Because the heart rate's low and the blood pressure was, there's no reason to have them on 2 chronotropic agents. Hemoglobin A1C of 6 in an 86-year-old, they don't need metformin. I stopped the allopurinol because we stopped the furosemide and the potassium, because those things are not necessary and they have anticholinergic activity and the blood pressure was low. The oxybutynin, that should just be forbidden in patients that get older. Don't know for sure that this patient has depression. We see this all the time on our programs when we bring them on. And that has to do, again, I think we are over-treating. PHQ-9s of 10 or higher does not mean that they have depression. That means that they may have depression. And a PHQ-9 of 10 to 15, for example, we see those all the time. The chances of the patient actually having depression is only 55%.
Why so much metoprolol?
Well,
Because you kept her on it.
no, we can stop it. We'll reevaluate. Hydrocodone, ibuprofen is independently associated with as are nonsteroidals with premature death in the elderly. It's a good medicine to stop all nonsteroidals. Tylenol PM, again, it's the diphenhydramine that's the problem. There's no medical evidence of the vitamins help. And if they're going to go off their Lasix, they're going to go off their potassium. There's 4 medicines up here, by the way, that increase this patient's chance of bleeding. Anybody know which are the 4? Aspirin, ibuprofen. What are the other 2? Paxil. Who got it? Yeah, thank you. Very poorly. It's not a cavalier medicine in the geriatric population. The SSRIs are associated with upper GI bleeds. They're associated with post-surgical bleeding. Yeah, and it's the potassium ER, because especially for patients with high anticholinergic burden, the pharmacist put out a warning that those patients cause erosive ulcers in the esophagus, and patients have bled to death. So this is what a palliative strategy looks like. Which patient what do you think the patient thinks when you take their medicines away and they feel so much better? They're more likely to be compliant, they control their costs, they don't have to come back to see you because they're feeling good. Here's some of the information. This was published last year. It was looked at statins. About 380 patients. Half of these patients had cancer, half did not. They took them off their statins because they visualized where they were in the bell curve. And what happened? The patients had statistically significant increases in quality of life when they went off of their statin, and they trended towards living longer, about 39 days longer when they stopped the statin. Stopped the statin. SSRIs increase the risk of falls and fractures. So they fall, I guess that's not a big deal, but these patients fracture at more than twice the rate. And it's also associated with more fractures and things we're used to thinking about in the advanced elderly, such as glucocorticoids and PPIs. Here's the polypharmacy data. I don't get to show a lot of research articles that look specifically at mortality and polypharmacy, but this is age 75 and this is age 80. This is a 5-year window for patients with more medications, and it has to do with the changes in the pharmacodynamics and pharmacokinetics of the geriatric population. This is greater than 10 medicines on the bottom, and that's 0 to 5 medications on the top. I think that 5 or less should be our goal for all of our geriatric patients. People would say, well, gosh, they need some of these medicines. Sure they do. But a lot of physicians would have looked at that initial medication list and said, well, that's just an appropriate list because we're treating all of those issues. Medicines that were appropriate when they had physiologic reserve and had the ability to metabolize those medications are now toxic and deadly. And you should stop as many medications as you can. Every geriatrician I know that I work with, or palliative physician, looks for how to stop medicines as soon as the first problem arises. The higher that anticholinergic burden, you can just look at their pills and know the more likely they are to develop delirium in their lifetime, and the more symptoms of delirium they'll have. Okay, that was sort of a review. How about just functional decline? We know people want to stay in their own homes. Can you tell this patient's likely, if they get institutionalized in the hospital, to develop hospital-induced functional decline? And the answer is yes. Here's the prognostic model made by Mark Sager, UCSF. Patient has all of these characteristics. Probability that this patient will develop functional decline is 55%. We can see it. How many patients of geriatric frailty syndrome does this patient have? And how many of us are looking for geriatric frailty syndrome in our advanced population? Because frankly, I think it's our fault. We've got our patients living so longer, it's a much more prevalent disease. And I actually agree with Joe. I had a very difficult winter in my own personal population because I lost 7 of my geriatric patients. But the average age of those patients was 91 and a half, because we're getting them to live so much longer, but we have to know how to stop medicines and adjust our care based on where they're at. I also think Joe's right on track when he talks about what we should be doing for our patients. Because And I see family physicians as taking ownership for this in the healthcare industry. The physicals, the Medicare physical is not quite, but almost worthless as our patients get older. But shouldn't we be doing things that are valuable to our patients, such as sending them to fall prevention classes before they fall, reviewing their medications so that they're not over-medicated, look at their IADLs, their ADLs, look at proper dietary recommendations before they have a problem? It doesn't help us when we're doing physicals that were based for a younger and healthier population, or when we're doing them too soon. So this patient has 5 of the 5 characteristics of frailty syndrome. This was adapted from Linda Fried's article for the American Geriatric Society. This is a physiologic syndrome, for those of you who aren't aware, characterized by decreased reserve, diminished resistance to stressors, resulting from cumulative decline across multiple systems and causing vulnerability to adverse outcomes. And we are going to see more and more of this. This is the pathophysiology of the syndrome. When cardiologists do a preoperative screen, what do for frailty? They do a 6-minute walk. That's the general tool they're using. The problem with that is that that's just the sarcopenic component of frailty, and the inflammatory component of the surgery itself tends to be ignored. The results of these pro-inflammatory cytokines leads to all of the diseases, so you can push the patient over the edge if you do too much to them. And you can also create the cognitive decline that they're trying to avoid. You can also use frailty as a predictor of surgical outcomes. How many people are using frailty when you see your patients to predict what's going to happen to them when they go to the hospital? This was done by Martin McCary. He's a surgeon and has a public health degree from Harvard. Lengths of stay for these patients will be twice as long. And that's unfortunate because the elderly lose 5% of their muscle strength per day when they're bedbound. We try to send them to the nursing home, and we know that they do not recover, especially if they develop delirium. Major complications go up by more than twice. That's a selling point to your hospitals because they don't want sick patients in their hospitals. If you can identify them ahead of time, and even if they do go, there's probably things you could do to assist in being sure those patients get taken care of. These patients are more likely, even after minor procedures, to be discharged to skilled facilities and assisted living. And for major procedures, it's 14 times higher. That same patient who did well at 70, now you can tell them, well, now you're 14 times higher to be institutionalized. Are you sure you want to do this? I have patients in my practice that are saying no. They're choosing no. I have a great orthopedic surgeon. That's not the issue. I promise you I will send you to him. But I want to be sure that you know the new risk based on your profile at this age. And they say no, just keep giving me the Vicodin. I'll keep coming in every month, unfortunately. Anybody following the 2012 National Surgical Quality Improvement Program guidelines for preoperative evaluation? Anybody's institutions doing that? These were actually set up with similar information that I've given you here. So I'm just asking, when I talk to my organization, to follow the guidelines which have been set up that we're supposed to be doing. You should be doing MMSE scores on every preoperative patient. You should be doing frailty evaluations on every preoperative patient. You should be doing prognostic laboratories on every preoperative patient to make sure they really want to have surgery. What I've shown you here, there's another group. People said, well, what other group is trying to make this change? And frankly, I think everybody's trying to do it. But the other group that's going to try to take ownership of the change in healthcare is the palliative movement. And I will tell you, there's only 6,000 certified palliative care providers in this country. There's no way palliative care providers can improve care at that level. So to me, the ownership of that change defaults to primary care, and you use palliative providers as a backup. The other part of palliative care is that most of it's in the hospital and not in the outpatient environment. Who's the front line? We are. And these same techniques that we use on palliative care to decrease mortality by 33%, a multi-institution study where the surgeons got preoperative palliative consultations, whether the patient went to surgery or not, mortality rates dropped by 33% at 6 months. Whether they went to surgery or not, the refusal to have surgery went from 5.6% to 19.7%. My question, David, would be in an ACO, what's the best way to control cost? Not do it in the inpatient, do it in the outpatient, or not do it? Not do it. Not for any other reason that the patient chose not to. So here's a palliative question. All of those issues have been shown to improve quality of life. Can you place them in order of the treatment benefit most likely to prolong their life? Anybody know what the one that's most likely to prolong a patient's life is? I heard a lot of whispering. Adequate pain control. Longitudinal study shows that for cardiac patients, you can decrease their mortality by 68% by getting them adequate pain control. You should not use nonsteroidals. We should be pushing opioids used properly. And that's interesting because the entire westernized Society of Cardiologists in the Western Hemisphere says that the management of refractory dyspnea and congestive heart failure patients, for example, is long-acting opioids. But nobody uses them, even in their own society. The next one would be preventing social isolation. How many people prioritize that when you see a patient? What are we going to do today? You have a script for preventing social isolation for these folks. The third would be stop their cholesterol medication. And the only one that hasn't been proven to improve outcomes is treating depression. They're less depressed, but they die as quickly. So as we move forward, and what we're doing in SHARP is recognizing that we cannot take a homogeneous group of patients and call them all geriatric patients. We have to look at these patients differently. And then we're going to have to balance the patient-centered quality outcomes with our historic values in organ system disease benefits. And by proactively managing these patients and having discussions, something we're really good at, getting paid for talking, and being fair to our patients about what their true risk is, we can provide better care outcomes and lower the patient's cost. And that's what it looks like graphically. And when do you know to start looking at this? When those patients start to develop frailty, going into frailty, and you start to see the physiologic changes of their age. I think the issue that gets the physicians involved most is that we own this. We may not have recognized, and I know the surgeons didn't when I speak to them. I would say one of the pearls about speaking to your colleagues is I believe they care as much as we do. We just have to work together to make them recognize there's other issues. Spent 30 years working in nursing homes, watching the aftermath of care that they didn't understand. And patients would ask me this, and the families would ask me this as I reviewed how they got to be where they were, whether they were on hospice or in the nursing homes. And they would ask me, why didn't anybody tell me? We would have chosen otherwise, a different strategy, had I known that that risk existed. And to me, that's how we're going to be able to dramatically control the cost, because we're doing such a good job getting patients to a much more advanced stage. So with that, I'm happy to answer any questions. Yeah, Dr. Dave.
This is a fantastic presentation. Taking lots of notes about things that I want us to do differently in my organization. One thing I wanted to add is that I had the experience with my father having to make the decision to put him on what the VA, they were calling it